Hey class, in this video we're going to talk about pulmonary embolism. Here are the learning objectives for the video. So we're going to talk about the pathophysiology of pulmonary embolism and how it causes right heart failure and obstructive shock. Talk about risk factors for pulmonary embolism, common signs and symptoms, how to use a D-dimer and a clinical decision tool like the Wells score in the evaluation of PE, and then describe different treatment strategies based on risk stratification, when to pick certain types of anticoagulation, and deciding how long to treat patients with anticoagulation. All right, let's talk about the pathophysiology of blood clots. So you need some kind of endothelial injury, abnormal blood flow, or hypercoagulable state that leads to activation of the clotting cascade, and you can develop clots in your deep veins. And these venous clots can break off and they can embolize to your lungs where they occlude the pulmonary arteries. And that's going to cause a sudden increase in pulmonary vascular resistance and pulmonary artery pressures, which is going to cause right ventricular dilation and increased wall tension, oxygen demand, which can lead to right ventricular ischemia and decreased RV contractility. And because you're not getting blood through the pulmonary arteries to the left circulation, you're going to have decreased LV filling, which is going to lead to reduced stroke volume on the left and hypotension, which is going to worsen the ischemia. Just want to remind you about Virchow's triad, where you need to have either an endothelial injury, abnormal blood flow, or hypercoagulability to develop a blood clot. Usually you have two or three of those things. So you can imagine if you just had like a big leg surgery, you might have injury to the endothelium. You're going to be not moving around too much after that surgery, so you're going to have abnormal blood flow, and maybe you also have like a factor V Leiden heterozygous mutation that makes you more prone to thrombosis. All those things can conspire together to create a blood clot. Now, you can't have a talk about blood clots without putting a picture up of the clotting cascade. Just wanted to remind you that on the left is the clotting cascade as it works in the laboratory, whereas on the right is how it actually happens in your body. So if you have endothelial injury, vascular damage that exposes tissue factor, you're going to activate factor 7, which in turn activates factor 10, which activates prothrombin to thrombin, which can then convert fibrinogen to fibrin clots. And this is mostly interesting because it helps you also remember what some of our targets are for medications like factor 10 and factor 2. Now, normally pulmonary vascular resistance is very, very low. Vessels are arranged in parallel and they have a very large surface area. And you might remember from physics that when you arrange circuits in parallel, you actually have lower resistance overall compared to arranging circuits in series. So with the pulmonary vessels, you have lots of different vessels arranged in parallel with a very large surface area that keeps resistance low. And because of that, the right ventricle usually doesn't have to work that hard, and it's not a very thick muscle. Now, when you have thromboemboli occlude vessels, you're going to reduce that surface area, and a reduction in radius leads to large increases in resistance. There's Poiseuille's law again. We just can't get away from it. And because of Ohm's law, if we increase pulmonary vascular resistance, we're going to have to also increase pulmonary artery pressure to maintain the same right ventricular cardiac output. And Laplace's law tells us that if we increase pressure, that's going to increase wall stress and myocardial oxygen demand. So that's going to increase oxygen demand in the right ventricle, which can cause right ventricular ischemia. And this can set off a very dangerous spiral where if you have RV ischemia, you're going to have a loss of RV contractility and a decrease in right ventricular output. That's going to lead to less filling on the left side and a reduction in left ventricular cardiac output, which leads to hypotension and shock, and it can quickly turn into a death spiral. Now, the type of shock caused by a pulmonary embolism is classified as obstructive shock. And there's 4 broad categories of shock you should think about when you have a patient with hypotension: hypovolemic, cardiogenic, septic, and then obstructive. And obstructive is going to be cardiac tamponade, pneumothorax, or a pulmonary embolism. And you're going to have a low cardiac output, and in response to that, you're going to have a high systemic vascular resistance, Right atrial pressures are going to be very high because the pulmonary arterial pressures are high, and pulmonary capillary wedge pressure will be low because you're not getting blood from the right to the left because of the obstruction. That's how you can differentiate it from other types of shock. There are a lot of risk factors that can cause blood clots, and I won't read this whole chart to you, but you can see that strong risk factors would include things like surgeries, like hip or knee replacements, fractures, major trauma, and hospitalization. But it's important to know that cancer and then other inflammatory diseases like rheumatoid arthritis, inflammatory bowel disease, or infections also increase your risk of blood clots. But really, everything on this chart can increase your risk of a blood clot, so you have to do a pretty good history for your patients. All right, symptoms of pulmonary embolism include dyspnea is the number one. They can also have pleuritic chest pain, syncope or lightheadedness. Hemoptysis is not all that common, but I always ask. Leg pain or swelling could be suggestive of a deep vein thrombosis in the legs. Fever is a symptom of blood clots. It's not very common, but if you have a patient with a fever that doesn't seem to be from an infection, you should always consider blood clots. And then fatigue is another common symptom. Physical exam findings in pulmonary embolism can be kind of challenging because they're fairly nonspecific and not always very sensitive. You can see from this chart here that, the sensitivity, specificity, and likelihood ratios are not great for any of these things. But if you have a patient with tachycardia that you can't explain, you should think about pulmonary embolism. Same with tachypnea or hypoxemia. You could hear a pleural rub. I've never heard a pleural rub, but that is a potential exam finding in PE. Prominent P2, I have heard that before. And then always check for unilateral leg tenderness or swelling. That might be a sign of a deep vein thrombosis. Chest x-ray is not super useful for diagnosing pulmonary embolism, but it is useful for evaluating for other causes of dyspnea. So if you have someone coming in with shortness of breath, you should always get a chest x-ray. You can look for alternative diagnoses like pneumonia or heart failure. There are some chest x-ray findings, though, that you might see. A Westermark sign is, we have a focal area of loss of blood flow because of a pulmonary artery occlusion. The Hampton's hump, you can see a wedge-shaped infiltrate due to pulmonary infarct, and you might have a unilateral pleural effusion. So this is just showing you that Westermark sign where you have a pulmonary artery occlusion and there's no blood flow in that area, so you have that focal area of oligemia. Hampton's hump is showing you this nice wedge-shaped infiltrate where you had a blood clot lodged in that pulmonary vessel, and that lung infarcted, and now you can see a bunch of inflamed dead lung tissue there. Arterial blood gas might be useful in pulmonary embolism. Usually just shows a respiratory alkalosis because the patient might be breathing really quickly or hyperventilating. That's nonspecific. Most patients with hypoxemia will develop a respiratory alkalosis. Usually you're going to have an abnormal AA gradient as well because of VQ mismatch. But it is important to note that not all patients with pulmonary embolism are hypoxemic. But if you do have a hypoxemic patient without an explanation, you should evaluate them for pulmonary embolism. Electrocardiogram is an important test in patients with acute dyspnea and chest pain. Obviously, you want to look for things like acute coronary syndrome as well. The most common finding in pulmonary embolism is going to be sinus tachycardia, but you also want to look for signs of acute right heart strain like the S1Q3T3, which is kind of the classic PE finding, but not usually present. You might also see T-wave inversions in V1 through V4 or an incomplete or transient right bundle branch block, and you can also see atrial fibrillation. So here's a cool EKG from somebody with a pulmonary embolism. You see that they have sinus tachycardia. They have an S wave in lead 1, which usually you don't have an S wave there. They have a really deep Q wave in lead 3, so that's your Q3. And then they have a T wave inversion in lead 3, so that's S1 Q3 T3. It's a sign of acute right heart strain. They also have an incomplete right bundle branch block, so you can see they have that RSR prime or bunny ears morphology there. And they have T-wave inversions in leads V1, V2, V3. So they have lots of different findings of right heart strain from an acute pulmonary embolism. D-dimer is a useful lab test in evaluation of blood clots. It's a fibrin breakdown product. So you remember at the very end of the clotting cascade, after you've cross-linked your fibrin, you have activation of plasminogen to plasmin, which then chops up the fibrin into degradation products, including D-dimers. So if you see D dimers in the bloodstream, you know that there is activation of the clotting cascade. So it's very sensitive for pulmonary embolism, like 98% sensitive. And it has a pretty good negative predictive value when you pair it with a decision tool. But it's not very specific because it can be elevated for a lot of reasons: surgery, trauma, cancer, infections, pregnancy. So a lot of patients in the hospital are going to have a positive D dimer and not have a blood clot. So the Wells score can help you estimate the pretest probability that your patient has a pulmonary embolism. And you can see the components here. I don't have it memorized. I just pull it up on MD Calc. But you want to see, does your patient have symptoms of a DVT? Is PE the most likely diagnosis? Are they tachycardic? Did they have recent surgery or immobilization? Have they ever had a clot before? Are they coughing up blood? And do they have active cancer? So you total up the points. If they're less than 2, so 0 or 1, they're going to be low probability. 2 to 6 is intermediate, and above 6 is high probability. Now you can use the Wells score and the D dimer to rule out the diagnosis of pulmonary embolism for patients with low and intermediate pretest probability. So if they're in that low intermediate range and they have a D dimer less than 500, that has a good enough negative predictive value to rule out a PE, meaning in the studies where they validated this, those patients had less than 1% risk of a PE in 3 months. If they have a high pretest probability, then a negative D dimer does not help you exclude a pulmonary embolism. So this is a great illustration of Bayes' theorem, which is the mathematical rule you use to update the probability of something being true after you get new information like a test result. So you say, what is my pretest probability that the patient has a pulmonary embolism? And then we get the D dimer, and now that we have the result, say it's negative, what is my post-test probability? And you can calculate the negative likelihood ratio of a D dimer. It's going to be 1 minus the sensitivity of the D dimer over the specificity. So for a D dimer, the sensitivity is 97%, the specificity is around 45%, so the negative likelihood ratio is going to be 0.067. The pretest probability, let's say, is 10%, low pretest probability. You can convert that to pretest odds, which is 0.11. Multiply that by the negative likelihood ratio of a negative D dimer, and you get 0.007. And then you convert that to post-test probability, and that's going to be 0.73% post-test probability of a PE. So this is showing you that in someone with a low pretest probability and a negative D dimer, they have a very low post-test probability of a PE, less than 1%. Now that's a lot of math. You can actually use nomograms for this, where you find the pretest probability and you draw a line through the likelihood ratio, and it'll give you the post-test probability. Now, what if your pretest probability is high? Say it's 65%, and you get a negative D dimer. Well, you can see that if you do the math, that your post-test probability of a PE is 11%. So that is much too high to accept without doing further testing. So you have not ruled out a PE with a negative D dimer if someone has a high pretest probability, which is why we don't bother checking D dimers in people who have high pretest probability. And you can see with the nomogram, again, you find that pretest probability on the left, draw a line through the likelihood ratio, and you find that post-test probability. Now, the normal D dimer cutoff is less than 500, but the specificity of the D dimer does decrease with age. And so people wondered, what if we used an age-adjusted D dimer? And so you can multiply the age of the patient by 10 micrograms per liter, and that will give you an age-adjusted D dimer. This was validated in a large cohort of patients, and so we do often use age-adjusted D dimer. So if I have a 65-year-old patient, their D dimer cutoff would be 650. Now, what about patients whose likelihood is so low that you don't even think a D dimer is necessary? So people did develop the PE rule-out criteria that you can use in the emergency room to identify those people where their likelihood of a PE is so low that you don't need to do any testing. And so you should only use this in people who have a low pretest probability already. And so you can use a Wells score for that, or like the original criteria, they just said use your clinical gestalt. And if any of the components are positive, then you can't rule out a PE. But if all the components are negative, then the probability of a PE is less than 2%. And these are the PE rule out criteria. So all of these have to be negative. And if they're all negative, you can say you do not have a PE. We're not even going to test you with a D dimer. Now, for patients with a high pretest probability or patients who had a low or intermediate pretest probability and a positive D dimer, the next step is to get a CT pulmonary angiogram to look for pulmonary embolism. It's a very sensitive and specific test. You can have some false positives. Now, if the patient can't get a CT scan because they have a severe contrast allergy or they have renal failure and someone's afraid to give them contrast, you can get a ventilation perfusion scan as an alternative. Now, here's an example of a CT pulmonary angiogram. You can see as we go down, see the pulmonary trunk there, and on the right side is a large pulmonary embolism. And as we continue to scroll down, you can also see that the right ventricle is more dilated than the left ventricle, which is suggestive of some right ventricular strain. Once you've diagnosed someone with a pulmonary embolism, the next step is to risk stratify them. And the first step in that is the Pulmonary Embolism Severity Index, or PESI score. You can see all the components there. Again, I don't memorize this. I just pull it up on MD Calc, and you get a score. And based on that score, you can say this is a low-risk person, they have a very low mortality risk, or this is a high-risk person, and they should probably be admitted to the hospital. So patients with a PESI class 1 or 2 are considered low risk and they're appropriate for outpatient treatment usually. You can also use a simplified PESI score. So as long as they have a score of 0 for that, they're okay for outpatient treatment. Intermediate risk is going to be your PESI class 3 to 5 with a normal blood pressure. And then patients with shock or blood pressure less than 90 millimeters of mercury, we call them high risk PE. Sometimes you'll hear people call them massive pulmonary embolism. But that gets confusing because it sounds like you're describing the size of the clot, not the fact that they're in shock. Now you can further stratify your intermediate risk patients by looking at RV dysfunction on echo or CT scan and positive biomarkers. So you see here that if you have normal blood pressure, PESI class 3 to 5, RV dysfunction on echo or CT scan, and a positive troponin, that would put you in the intermediate high risk category. And this is trying to identify patients that are higher risk for bad outcomes in the hospital. Echocardiography can be useful in pulmonary embolism. You can look for RV dysfunction, which often shows up as an RV to LV ratio over 1 or a decreased TAPSE. Those are both associated with worse outcomes. You might see depressed contractility of the RV free wall compared to the apex. That's called the McConnell sign. And you might see flattened intraventricular septum suggestive of RV overload. Now, about a quarter to a third of the population has a PFO. And when you have a pulmonary embolism, you're going to have elevated right-sided pressures, so that might actually result in some shunting across that PFO. So you can do a bubble study to look for that. Occasionally, you'll see blood clots in the right atrium or the ventricle, but fortunately, that's pretty rare. And the echo can be useful to identify other causes of shock like tamponade, acute valve disease, severe LV dysfunction, dissection, and hypovolemia. Now, not everyone needs an echo, and I would argue that most patients do not need an echocardiogram because biomarkers are actually just as good at identifying patients with RV dysfunction, and they're cheaper and they're faster. Now, this chart shows odds ratios for all-cause mortality and PE-related mortality for your imaging findings and your biomarkers, and you can see that positive troponin, positive BNP, and lactate all perform as well or better than your imaging studies for predicting all-cause mortality. Now, in February 2026, the American Heart Association and American College of Cardiology came out with new guidelines for acute pulmonary embolism. And in those guidelines, they proposed this new classification scheme. And you don't need to memorize this. I just want you to be aware that it exists because I think we probably will be using it more in the future. But basically, on one side, you have A, these are the lowest risk patients. On the other side, you have E, these are the high risk patients with cardiogenic shock. And I think these new classifications will help us, be more precise in defining patients for clinical trials. So I think there'll be some utility there, but it probably won't change a lot of management in the short term. Now, one question that comes up with patients with pulmonary embolism is who benefits from reperfusion therapy. So, tissue plasminogen activator, your body makes it, but we can also give it as a drug. It converts plasminogen to plasmin, cleaves fibrin, and breaks down clots. And if we can give that medication to somebody, we can break up that clot, reduce their pulmonary vascular resistance, and improve their cardiac output, hopefully save their life. But who actually will benefit from that treatment? Well, the biggest trial that's asked that question was the PYTHO trial that was published back in 2014, and it was looking at using thrombolysis in patients with intermediate risk pulmonary embolism. Now, the PYTHO trial enrolled 1,000 patients with intermediate risk PE. They were randomized to heparin plus thrombolysis with tenecteplase or heparin plus placebo. And the patients were defined as intermediate risk if they had normal blood pressure, RV dysfunction on echo, and a positive troponin. So they would have been that intermediate high risk category. And the primary outcome they were looking at was death or hemodynamic decompensation within 7 days. And that did occur less frequently in the thrombolysis arm, but there was no difference in death between the two groups. There was more hemodynamic decompensation in the placebo arm. So you can see 5% of the placebo arm patients had hemodynamic decompensation, which was defined as these things. Most of them had transient hypotension. Now, the trade off was there was a lot more bleeding in the thrombolysis arm. Not surprising. They had more major extracranial bleeding, more strokes, and more hemorrhagic strokes with a pretty high case fatality rate. Now, if you pool all the trials that have been done on thrombolysis, and PYTHO was the biggest one, you will see in this forest plot that thrombolytics probably do improve mortality for patients with pulmonary embolism. And so the number needed to treat to save one life is about 59. However, the number needed to harm to cause major bleeding is 18, and to cause an intracranial hemorrhage is 78. And so, based on that, we reserve systemic thrombolysis for patients with high risk PE, so those patients with obstructive shock, because in those patients, the benefits outweigh the risks. Not recommended in low risk patients or with intermediate risk PE. But I do think it's nice that PYTHO trial showed that 95% of intermediate risk patients do fine with anticoagulation alone, and maybe 5% will decompensate in the hospital and they might require rescue therapies. Now, before giving thrombolysis, you should always review your contraindications. Have they had a stroke in the past? Do they have, brain metastases, recent trauma or surgery, things like that? So people have tried to figure out ways to do reperfusion therapy without the high bleeding risk. And so one way to do that would be catheter-directed thrombolysis, where you actually put catheters into the pulmonary arteries and you infuse lower doses of TPA directly into the pulmonary arteries to try to dissolve those clots. But there is still some bleeding risk with that because you're using TPA. Another approach, shown by the picture on the right, is to do thrombectomy, where you actually put the catheter into the pulmonary arteries and then you suck the clot out. So there aren't any studies of these that actually show improvement in patient outcomes. Most studies use surrogate outcomes like the change in the RV to LV ratio, but no one has actually proven that these reduce mortality, bleeding, or recurrent PE compared to anticoagulation alone. There are some big randomized trials going on, including some here at the University of Utah. So currently, I would say that these catheter-directed therapies should be reserved for patients with high-risk PE who are not candidates for systemic thrombolysis or patients who have persistent shock despite systemic thrombolysis. But I don't think that they're probably indicated for most patients with intermediate risk PE. Now, you might see patients with intermediate risk PEs getting these procedures, and there are people that believe very strongly that these procedures do benefit those patients. And to those people, I would just say, well, that's just like your opinion, man. All right, so for initial anticoagulation, it's important that you start it very promptly to prevent further development of thrombus. And if you have a patient with a very high pretest probability for PE and they have a low bleeding risk, it's reasonable to give anticoagulation even before you get the CT scan. For patients that are going to be admitted to the hospital, I think it's best to start with a low molecular weight heparin, such as enoxaparin, and that is supported by the latest guidelines. Enoxaparin has very predictable pharmacokinetics, it's very convenient to dose, and it has a much lower bleeding risk than unfractionated heparin infusion, and there's just less room for error. Heparin infusions require nurses to check labs and adjust the rate and things, and there's just like a million ways to screw them up. Low risk patients can be discharged home and they can be started immediately on oral anticoagulation, preferably with a DOAC like apixaban or rivaroxaban. So these are options for direct oral anticoagulants. Dabigatran is a factor 2 inhibitor. It's the original DOAC, the first one to go generic. And so if I have a patient who can't afford apixaban, I might do dabigatran. You can go to costplusdrugs.com and get it for pretty cheap. And then your factor 10A inhibitors include apixaban, rivaroxaban, and edoxaban. All of these drugs are first-line agents for venous thromboembolism. They've been shown to have a lower risk of major bleeding compared to warfarin, and they don't require any monitoring like warfarin, and the therapeutic onset is nearly immediate. Now, you should know that for dabigatran and edoxaban, the package insert requires you to bridge with low molecular weight heparin for like 5 days, which is probably why nobody uses these drugs. You should also know that DOACs are the preferred agents in patients with cancer-associated thrombosis. Now, which is the best DOAC? I've had a suspicion all these years that it was probably apixaban, and we have a lot of retrospective data that suggests that, but we finally got a head-to-head study between apixaban and rivaroxaban published in March of 2026, the COBRA trial, and in patients who were being treated for venous thromboembolism in those first 3 months, apixaban was associated with a much lower risk of clinically relevant bleeding. So I think if you're going to pick one, pick apixaban. Now, if you're prescribing DOACs, you should consider contraindications. Probably the most common contraindication is that it's too expensive for the patient. Hopefully that's going to change in the future as these drugs go generic. If you're pregnant or breastfeeding, low molecular weight heparin is preferred, or you can use warfarin as well in breastfeeding. People with Child-Pugh C cirrhosis, so advanced cirrhosis, should avoid DOACs because they are metabolized in part by the hepatobiliary system, so it could increase their bleeding risk. Patients with antiphospholipid syndrome, there's multiple trials that show warfarin is better than DOACs in those patients. People who got the DOACs were more likely to have arterial thromboses, so we do put those patients on warfarin. And then consider drug-drug interactions because DOACs are metabolized by CYP3A4, so if you have strong inducers or inhibitors of those, then you should maybe not use DOACs. Also be mindful of people with gastric bypass and small bowel resections. They may not be absorbing the DOACs very well. Rivaroxaban is absorbed significantly in the stomach, and so I avoid rivaroxaban in those patients. But apixaban is probably okay because it's absorbed throughout the GI tract. All patients with a pulmonary embolism require at least 3 months of anticoagulation. So if you're discharging a patient with a PE, make sure they have at least 3 months. Patients who had an unprovoked clot, so this clot just came out of nowhere, there's no obvious reason, they didn't have surgery or immobility or anything like that, they should stay on anticoagulation indefinitely because if you stop anticoagulation, they have about 30 to 40% risk of recurrence. Patients who have a persistent risk factor, like cancer, should remain on anticoagulation as long as that risk factor is present. So if they do have cancer, we keep them on anticoag until their cancer is in remission. If they have antiphospholipid syndrome, that's going to require lifelong anticoagulation. Patients with a blood clot due to a major transient risk factor like surgery have a very low risk of recurrence, about 3%. And so you can stop their anticoagulation after 3 months. And then if that patient's having a high risk situation in the future like surgery, you would use prophylaxis to try to prevent a blood clot. Patients with a blood clot due to minor transient risk factors have a low risk of recurrence, about 15%. And so the 2021 CHEST guidelines suggest stopping anticoagulation after 3 months. The new 2026 guidelines suggest shared decision making. Consider long-term anticoagulation for patients who might have persistent risk factors like obesity. So your major transient risk factors are surgery, hospitalization for 3 days, C-section, and major trauma, and those are associated with a very low risk of recurrence, like 3%. Your minor transient risk factors are going to be shorter surgeries, short hospital stays, hormone associated, bed rest at home, leg injuries, and long haul travel. And those are associated with like a 15% recurrence risk at 5 years. Now, not all risk factors are the same, right? We know that risk factors are going to exist along a continuum, and every patient is going to have a different risk of recurrence. And if it was provoked by a major surgery or trauma, they have a very low risk on the right. If they have antiphospholipid syndrome, then they have a very high risk of recurrence. It's very obvious that those people need to stay on anticoagulation. But for the people in the middle, it's not as clear. People who had a blood clot provoked by oral contraceptive medication or an 8-hour flight, those people have a higher risk of recurrence in the future. So it's not exactly clear what we should do with those people for duration of therapy. But we kind of had to just pick an arbitrary line, which we're saying is those minor transient risk factors. And on one side, we treat them for 3 months, and on the other side, we do indefinite anticoagulation. And I think we'll do more studies in the future that will help us maybe be a little bit more nuanced about this. There were some trials that came out in 2025, the RENOVE trial and the APICAT trial, that both showed that in patients who need long-term anticoagulation and they're on a DOAC, you can actually use half-dose DOAC, and it's just as good at preventing blood clots, but you get a significant reduction in bleeding risk. And so the 2026 AHA-ACC guidelines do recommend using half-dose DOAC in people on extended treatment. One question that comes up a lot is whether we should test patients for inherited thrombophilias. So it turns out that the presence of an inherited thrombophilia is a pretty weak predictor of recurrent VTE in patients with the very first episode of VTE. And some mutations like factor V Leiden are pretty common and they're not associated with an increased risk of recurrence. Now, there are other inherited thrombophilias like protein C, protein S, and antithrombin deficiency that are associated with a high risk of recurrence, but they're pretty rare and they're usually going to manifest at an early age, and those patients will have a strong family history. So you should really only test people for thrombophilias if it's going to change management. So if they had an unprovoked clot, it doesn't really matter if they have a thrombophilia or not, so I wouldn't test those people. If it was provoked by a major transient risk factor like a surgery, they still have a pretty low risk of recurrence, so I wouldn't test in those people. I think in patients who had a PE provoked by a minor transient risk factor and they have a strong family history, you might consider testing for inherited thrombophilias if you think it will change management. The other thrombophilia we should think about testing for is antiphospholipid syndrome, which we've mentioned a few times in this video. It is associated with a much higher risk of recurrent clots and mortality. And because warfarin is the preferred treatment, it does change management if you know the patient has antiphospholipid syndrome. So I test a lot of patients for this. If they're young and have an unprovoked clot, like and they're less than 50, if they have a clot in a weird place, like a portal hepatic mesenteric clot, patients with autoimmune diseases like lupus, rheumatoid arthritis, and then patients who've had obstetric complications and a blood clot, I will test them for APS. When you test people for APS, you're going to test for 3 different antibodies: the lupus anticoagulant, anticardiolipin, and beta 2 glycoprotein 1, IgM and IgG. You got to test for all 3. Now, the lupus anticoagulant can be falsely positive if the patient has been receiving anticoagulation like heparin. So ideally, you would pause that to test, which you don't want to do in those first 3 months after diagnosis. So usually this is something you can do later. If any antibody testing is positive, you got to repeat it in 12 weeks to confirm, because these antibodies are frequently transient and will go away. But if they're still present in 12 weeks, then that confirms the diagnosis. If they have all 3 antibodies, we call that triple positive APS, and they have the highest risk of bad outcomes. Now, some patients with pulmonary embolism will go on to develop chronic thromboembolic pulmonary disease. And so if you have a patient with persistent symptoms of dyspnea 3 months after their PE, you should evaluate them for this. And the testing includes getting an echocardiogram to look for signs of pulmonary hypertension, get a VQ scan to look for perfusion defects, and also get cardiopulmonary exercise testing. And patients who have abnormal testing should undergo right heart catheterization so they can evaluate for pulmonary hypertension. Patients who do have this condition should receive indefinite anticoagulation. And if they have advanced disease, then they'll be considered for pulmonary endarterectomy, which is a very morbid surgery. pulmonary artery balloon angioplasty, or a medication called riociguat. All right, we covered a lot of ground in this video. Here's a summary slide with some of the key points. Hopefully, you feel much more confident now in diagnosing and managing pulmonary embolism.